is
Dr. Vidal.
and we will be presenting to you a demonstration of arterial blood gas sampling. So we will now demonstrate to you the modified Allen test. This is done para ma-check natin yung adequacy or yung patency ng flow dun sa upper extremity by doing this to the radial and ulnar arteries. So first, you'll ask the patient to position his arm like this and then occlude with your fingers the radial artery and the ulnar artery. And then observe for blanching as you instruct the patient to open and close their fist rapidly. So ayan, nakita natin merong blanching sa palm niya and then release first one of the arteries, first the ulnar, and then check kung merong rapid na balik ng blood flow. If there is, meaning patent or adequate yung blood flow dun sa area na yun. And then the other artery naman. So as you can see, Dr. Vidal's upper extremity arteries are normal. So now we will show to you how you get an ABG sample. So the idea, syempre, sa lahat ng gagawin natin, you explain first to the patient anong gagawin mo, no? So Dr. Vidal, ang gagawin ko po sa inyo ngayon ay kukunan ko po kayo ng dugo galing po dito sa tumitibok na ugat ninyo sa may wrist ninyo. So pumapayag po ba kayo doon sa procedure na to? So syempre, kailangan explain niyo para saan siya, ganyan. It's not the scope of the demonstration anymore. So ayan, after that, first you palpate the artery using your non-dominant hand. Kasi syempre, yung dominant hand mo, yun yung gagamitin mo pang handle ng syringe. So using your two fingers, trace the artery. Dapat nararamdaman yung tibok ng artery doon sa dalawa mong fingers. Bakit? Kasi ang idea is itong pointer ko, yun yung magiging marker kung saan ako tutusok. Tapos itong middle finger ko, yun yung magiging marker kung hanggang saan ako pwede tumusok. The angle na gagamitin natin ay 30 to 45 degree angle para makuha natin yung artery mismo.
Hello, doctor. So earlier, Dr. De La Rosa explained to you the procedures on how to prepare for the ABG sampling. So I will now be demonstrating to you how to get the actual sample. Okay, so first we palpate for the radial pulse. So pwede kong gamitin itong dalawang fingers ko. So first is the index finger in order to mark kung saan ako tutusok, and then the other finger in order to feel kung saan ka pwedeng mag-thread along pag pinasok mo na yung syringe. Okay, so after feeling for the pulse, we clean our hands using an alcohol. Clean the site of injection as well. Wipe the alcohol off. And then prepare your syringe. So ideally, we will be using a 1 cc syringe pre-filled with heparin. So usually, yung ginagamit natin na amount ng heparin is only about 0.1 cc. Then usually, what we do is we pull back and then we push back the heparin in order to coat evenly the syringe. Okay, so after that, reminder lang na dapat yung needle natin naka-bevel up. Okay, so the entry should be, the opening should be above. And then the angle of insertion should be around 30 to 45 degrees. Also, it's also ideal to set a roll of gauze or tissue or anything that could stabilize yung buong arm, no? Para at least taut yung skin and hindi kayo mahihirapan kapag pumasok na kayo with your syringe. Okay, so I will now be inserting. Warn your patient, ma'am, papasok na po ako ha, kuha na po tayo ng dugo, huwag pong kakabahan. Okay, hinga po malalim. Okay, so now we have inserted the syringe and then nakita natin na meron tayong backflow, no? So afterwards, you can pull up rather, and then fill slowly the syringe up to the certain amount that you will be needing. So it is important also na meron ka nang nakahanda, naka-prepare na gauze or tissue na meron ng tape, okay? So afterwards, you press on the injection site and then slowly pull. Ma'am, gilayin ko na po. After that, instruct the patient to press the gauze at the injection site for at least a minute kasi arterial pulse yan, medyo malakas yan, no? So hindi mo i-expect na magka-clot kagad yan. Okay, so after that, usually what we do with the syringe is we put a rubber stopper para hindi makapasok yung air sa loob and then pwede kasi makontaminate yung arterial blood gas mo. So after that, you put it in ice and then you submit it to the laboratory.
We will be talking about interpretation of acid blood gas. So you will definitely be involved in the acute care of patients at the AR or ICU. Hence, it is important that you should be able to correctly interpret and correlate ABG parameters. So let's start with the basics. As you all know, if arterial pH is low, the primary disorder must be an acidosis. If the arterial pH is high, the primary disorder is an alkalosis. The simple assumption is that bicarbonate change reflect metabolic events, whereas changes in your PCO2 reflect respiratory events. Abnormal combinations of pH and PCO2 and bicarbonate can be designated in terms of a primary disorder and any compensation that might be present. Now, when a secondary or compensatory change is present, it will attempt to restore pH toward normal. But this effect should remain incomplete, meaning each of the compensatory responses returns the pH toward normal, but the pH remains abnormal in the same direction as the primary change. It is also important to remember that complete respiratory compensation takes hours, but full renal compensation takes several days. This figure shows the acid paths in metabolic disorder. If you have a patient with uncompensated metabolic acidosis at the level of 7.2, your bicarbonate will decrease in order to restore your pH towards normal. In the same way, if you have an uncompensated metabolic alkalosis, your normal PCO2 will compensate by increasing its level to 48, hence attempting to restore your pH towards normal. Another very important principle to remember is that normal values of bicarbonate in PCO2 and pH do not ensure the absence of an acid-base disturbance. For instance, you have an alcoholic who has been vomiting. This patient may develop metabolic alkalosis. The bicarbonate is high, the PCO2 will compensate, and your pH is elevated at 7.5. If the same patient develop superimposed alcoholic ketoacidosis, your bicarbonate will go down to level 25. Your PCO2, because of the alcoholic ketoacidosis, will go down to level 40. Your pH will become normal. Hence, you will have a potential net effect of a normal ABG in a patient who actually has mixed metabolic alkalosis and metabolic acidosis. This situation is the key reason why we should always first measure your anion gap before attempting to interpret your ABG. Note as well that if your respiratory and metabolic parameters change proportionately, pH does not change. So you will have a mixed combination of primary disorders. Example, you have a normal pH, but your PCO2 is low and your bicarbonate is low. You have a normal pH in the presence of an elevated PCO2 and an elevated bicarbonate. The same direction of the two bicarbonate and PCO2 change makes your pH normal. Another mixed disorder arises when both parameters are altered in a fashion that changes the pH in the same direction, and neither change can be considered as a compensatory. Example, your pH is 7.1, so your pH is low. Now look at the PCO2. Your PCO2 is elevated and expected to cause lowering of your pH. Look at your bicarbonate. Your bicarbonate is low, which is expected to cause lowering of your pH. Which of the two is now the primary disorder? You might be dealing here with another example of a mixed disorder. This is an acid-base normogram, and this normogram shows that we have 6 acid-base disorder: metabolic acidosis, metabolic alkalosis, sorry about that, acute respiratory alkalosis, chronic respiratory acidosis, acute respiratory acidosis, chronic respiratory alkalosis. The reason why we have 6 acid-base disorder is because we have to deal with the fact on how the kidney compensates with bicarbonate. It takes a while. So the compensation will go up, go down, enough to negate the effects of the first thing that happened. So for you to be able to understand this acid-base normogram, I will attempt to simplify. Let's talk about the relationship of your PCO2 and your pH. Simply saying, let's say pH is proportional to the concentration of your PCO2. So there are two syndromes. If your PCO2 and pH are in the same direction, you are most likely dealing with metabolic. If your PCO2 and pH are in opposite direction, you are most likely dealing with respiratory as the primary disturbance. Okay. All right. So you have a PCO2 that is low and a low pH. You have a high PCO2 and a high pH. You have a high PCO2 and a low pH. You have a low PCO2 and a high pH. You have a high PCO2 and a low pH, but close to normal. You have a low PCO2 and a high pH, but close to normal. So if you have the same direction, you are most likely dealing with metabolic. If the change of your PCO2 and pH is in different direction, you're most likely be dealing with respiratory. So here, the change of your PCO2 and pH is in the same direction. You have a metabolic acidosis. Here, you have metabolic alkalosis. Here, you have an acute respiratory acidosis. Okay, and this one, you have an acute respiratory alkalosis. When your bicarbonate starts to compensate, then you will now have chronic respiratory acidosis and chronic respiratory alkalosis. So remember again, your bicarbonate takes longer to adjust in our body compared to PCO2 that can adjust itself almost immediately. So remember the two syndromes. If PCO2 and pH are at the same direction, the primary disturbance is a metabolic. If your PCO2 and pH are in opposite direction, the primary disturbance is a respiratory. This is the Winter's formula. This shows how a secondary compensatory mechanism responds. In every decrease, so this is bicarbonate over PCO2. So this is your bicarbonate, this is your PCO2. For every decrease by 1 of your bicarbonate, your PCO2 will attempt to compensate by 1. For every increase in the setting of metabolic alkalosis, for every increase of your bicarbonate by 2, your PCO2 will attempt to compensate by increasing by 1. Okay. Here, in acute respiratory acidosis, for every increase of your PCO2 by 10, your bicarbonate will compensate by increasing by 1. In acute respiratory alkalosis, for every decrease of PCO2 by 5, your bicarbonate will attempt to compensate by decreasing by 1. Okay. In chronic respiratory acidosis, it is 3:1. In chronic respiratory alkalosis, it is 2:1. Okay. So this is the approach to diagnosis. This is the stepwise fashion that is recommended when you try to interpret your acid blood gas. Okay. So number 1, you need to calculate the anion gap first. The formula is sodium minus chloride plus bicarbonate, and your normal anion gap is 12. If the anion gap is more than 12, it is considered to be high. And remember, there's only one acid-base disorder that can cause an anion gap, and that is metabolic acidosis. Next, you need to calculate your delta gap. Your delta gap is a formula that can be used to assess elevated anion gap metabolic acidosis and to evaluate whether a mixed acid-base disorder is present. So the formula here is you take the value of your anion gap and subtract it by 12. Take the value of the delta gap and add the current bicarbonate level. If the result is less than 22, you have concurrent non-anionic gap metabolic acidosis. If the result is more than 26, you have concurrent metabolic alkalosis. Now, after you have computed for your anion gap and your delta gap, start to interpret the direction of your pH and PCO2. If they are in the same direction, you are dealing with metabolic. If they are in an opposite direction, you are dealing with respiratory. Then, estimate the compensatory response using the Winter's formula, as I have shown you a while ago. Then finally, you need to interpret the presence of the primary acid-base disturbance and the concomitant acid-base disturbance. Okay. Remember, only metabolic acidosis can cause an ion gap. And you know that there are 4 main causes of high anion gap metabolic acidosis. You have lactic acidosis, you have ketoacidosis, toxins, and renal failure. So let's start with our first case. Our first case is a 50-year-old male, alcoholic, who presents at the emergency room due to vomiting. The pH is 7.38, the PCO2 is 39, the PaO2 is 90, the bicarbonate is 23. So Remember, your normal pH is between 7.35 to 7.45. Your normal PCO2 is 35 to 45. Your bicarbonate is 22 to 26. Okay. So looking at the ABG of this patient, pH 7.38, it's normal. PCO2 of 39, it's normal. Bicarbonate of 23, it's normal. If you don't understand the principle of correctly interpreting the ABG, you may not be able to identify if there is really an underlying acid-base disorder. You may be referring this patient as having a normal ABG. But in fact, if you measure the anion gap, you will be surprised to find out that the anion gap is at level 37, which is considered to be high. So you have a high anion gap metabolic acidosis, despite having a normal ABG. Now, the next step is to calculate the delta gap. Okay, subtract 12 from your anion gap, which is 25, then add 23, your present bicarbonate, to the computed delta gap, and the result is 48. This is considered to be elevated, and as mentioned a while ago, if you have more than 26, consider metabolic alkalosis. If you have less than 22, consider an anion gap metabolic acidosis. So since this is more than 26, you have a concurrent metabolic alkalosis. Look at the pH and PCO2. Of course, you're already aware that you have a normal pH and normal PCO2. Estimate the compensatory response using Winter's formula. The level of your bicarbonate is at 23. So from a normal of 24, it goes down to 23. So that's 1. PCO2 of 39 from normal of 40 to 39. So there is a change of 1. So you have a 1:1 change. Is that consistent with a metabolic acidosis? So look at the Winter's formula. Metabolic acidosis, you expect a compensatory response of 1:1. So final interpretation for this case, you have a mixed high anion gap metabolic acidosis and concurrent metabolic alkalosis. Okay, case number 2. You have a 65-year-old male smoker with chronic obstructive pulmonary disease presenting with decrease in sensorium. So it's quite a classic case of a COPD patient who are having exacerbation to have decrease in sensorium if they are retaining PCO2. So you obtain your ABG, the pH is 7.26, that is low. Your PCO2 is 60, that is high. Your bicarbonate is 26, that is considered normal. So you calculate the anion gap. You have an anion gap of 10, so you have a normal anion gap. Calculate the delta gap. Oh, sorry about that. This should be 12. Okay. So subtract 12 to the anion gap. You have 0 delta gap. So there is no concurrent metabolic. There's no concurrent anion gap metabolic acidosis or concurrent metabolic alkalosis. Now look at the direction of your pH and your PCO2. You have a low pH and you have a high PCO2. So this is opposite. You are most likely dealing with the primary respiratory disturbances. So since the pH is low, you have respiratory acidosis. So let's estimate the compensatory response. Your bicarbonate is 26, so from a normal of 24, it increased to 26, so you have 2. PCO2 is 60, so from a normal of 40, you have 20. So you have 2 is to 20 or 1 is to 10. Looking at the Winter's formula for respiratory acidosis, so that is a correct compensatory response. 1 is to 10 or 10 is to 1. Okay. So our final interpretation is we have acute respiratory acidosis. Okay, for our third case, you have a 40-year-old female who presents to the ER due to diarrhea. You obtain the ABG, the pH is 7.47, so it is high. Your PCO2 is 29, so it is low. Your bicarbonate is 22, so this is normal. Okay. So you calculate the anion gap. You have a normal anion gap. You calculate the delta gap, so you have 0 delta gap. There is no concurrent metabolic acidosis or concurrent metabolic alkalosis occurring. Look at the direction of your pH and PCO2. Your pH is high, your PCO2 is low, so you have an opposite direction. You have a respiratory problem, high pH, so you have alkalosis. Estimate the compensatory response. So from a normal of 24, your bicarbonate goes down to 22, so 2. PCO2 of 40 to 29, so 11. So is this acute or chronic respiratory alkalosis? Look at the Winter's formula. So look at the Winter's formula. You almost have a 1:5 ratio. So you are dealing with acute respiratory alkalosis. So our final interpretation in this case is you have acute respiratory alkalosis. Okay. So for our next case, we have a 65-year-old female diabetic presents with abdominal pain, vomiting, and diarrhea. So if you look at the case, parang given na, no? Diabetic with these symptoms, isipin mo baka meron siyang tinatawag na diabetic ketoacidosis. Okay. So you obtain the ABG, your pH is 7.25, so this is low. Your PCO2 is 27, this is low. Your bicarbonate is 12, so this is low. So you calculate the anion gap. Your anion gap is 32. You have high anion gap metabolic acidosis. Calculate the delta gap. So get the value of your anion gap, subtract 12, so you have 20. You add the current bicarbonate to 20, so you have 32. So it is more than 26. You have concurrent metabolic alkalosis. Look at the direction of your pH and PCO2. Your pH is low, your PCO2 is low. So they are in the same direction. You are most likely dealing with a metabolic as a primary disturbance. So since the pH is low, you have metabolic acidosis, as expected, because you already have a high anion gap metabolic acidosis. Now estimate the compensatory response. So your bicarbonate is 12, from 24 to 12, goes down to 12. From 40 to 27, it goes down by 13. So you almost have a 1:1 ratio. Is that consistent? with the compensatory response by Winter's formula. Yes, so 1:1 metabolic acidosis. So your final interpretation is you have high anion gap metabolic acidosis with concurrent metabolic alkalosis. So that will be the end of my lecture. I hope I was able to refresh your memory on the correct approach in ABG interpretation. Thank you everyone and good luck.